Good morning, my dear future doctors. This is Saturday, May 23, 11 in the morning, and I'm all by myself because the one student that was attending had problems with the microphone, so I was just with the headphones, so I will just record it and hope you're gonna watch it later because we are going to discuss a really important topic today. So first, what I wanted to do is to share my screen with you. Okay. Um, yes, we've discussed in the previous lectures. We've discussed um, central nervous system, one of the biggest chapters, cardiovascular, and the drugs affecting kidneys, I mean diuretics and antidiuretics. You've got here. I wanted to mention the chapters which we discussed, so I'm going to show you in the book. I'm trying to open it right now. Okay, I will show it here. So this is your book, Triptychate, and these are the contents. So what we did for the, I mean you were asking for the second midterm. So we did till first midterm was still here, general anesthetics and skeletal muscle relaxants. So the second midterm will be from the chapter 9. Okay, we've discussed drugs acting on central nervous system into two parts. We divided them. You've got here all the topics: sedative hypnotics, ethanol, anti-epileptic, and anti-Parkinsonian drugs. And the second part of it included psychopharmacological agents such as antipsychotics, anti-manic drugs, antidepressants, and anti-anxiety drugs. Those were about 9 and the chapter 10. And they were all about CNS. The next chapter we discussed was 11 and 12. Cardiovascular system. We've got antihypertensives and anti-angiofactorials. And the second part included heart failure and cardiac antiarrhythmics. Okay. Previously, we had drugs acting on the kidneys. This was a very small chapter. That is why I didn't divide it into two topics. So this gives us another extra lecture advantage. We've got that we'll have an extra lecture, and before the midterm, I will review all these topics. Okay, but today we're explaining new things. So we are explaining hormones and related drugs, which is in 3 parts in your books. Okay, divided into 3 chapters. It is chapter 14, 15, and 16. Okay, but I'm not going to talk about it in 3 lectures. I'm just going to do 2 lectures. Today will be the first part of it, and today I'm going to talk about the pituitary hormones, anti-diabetic drugs, and corticosteroids. And the next lecture, which is going to be on a Wednesday, I'm going to talk about sex hormones, contraceptives, types of contraception, and drugs acting on uterus as well, and lastly, thyroid hormones. Okay, so these 15 and 16 I will discuss on Wednesday. Sorry. And today we're going to talk about pituitary hormones, anti-diabetics, and corticosteroids. Okay. I hope everything was clear with that. So I'm just going to start with presenting today. So the first topic I will discuss with you is pituitary hormones. Okay, so I have prepared a PowerPoint presentation for you, which I'm going to share right now. Okay, let's give it a second before it's on. Okay, I will just check if yes, I am presented. Okay. That's me, obviously. So let's start with this slide. So, drugs affecting the endocrine system. This is all we've got all the list of the parts of the endocrine system. We've got hypothalamus, which is the conductor of this orchestra. We've got pituitary gland, which is hypophysis. You might know it as hypophysis. We've got pineal glands. These are all located within the brain. We've got thyroid glands and parathyroids, four of them. We've got thymus, and we've got very important pancreas here, which is not just the part of endocrine, but as well as exocrine system. Okay, because it's endocrine and exocrine gland as well. We've got adrenal glands here, and we've got glands. So this is all the endocrine system, and we're gonna talk about it separately about its format. First, let's start about the neuroendocrine system. As I said, hypothalamus is the conductor of this orchestra. Okay, is the head of all the controlling system. Okay, which releasing hormones and different types of releasing hormones that cause the pituitary gland to release stimulating hormones, and the pituitary stimulating hormones then lead to other parts of the endocrine system to release different types of hormones. Okay, so here by means of hypophyseal portal system, we've got yes, they are interconnected with this hypothalamus and the pituitary gland through the hypophyseal portal system, neuroendocrine, posterior and anterior pituitary gland. Okay. Here we've got the parts which I said: adrenal glands, thyroid, pancreas, pituitary, brain, because it included the three most important parts of the endocrine system, which was hypothalamus, which was pituitary gland and pineal gland. We've got ovaries, testes, and thymus. Okay, and this is how it works. This is the scheme of the hormone release. So we've got at the head of it, at the top of it, we've got hypothalamus, which is the which releases, or got here, growth hormone releasing hormones like this, GHRH. We've got corticosteroids releasing hormone. We've got thyroid releasing hormone. We've got another tropin releasing hormone, pituitary and prolactin releasing hormone, and so on. Okay, and all these releasing hormones stimulates anterior pituitary gland, which itself then stimulates other parts of the body, growth hormone, which is then in the liver produce insulin-like growth hormone, adrenocorticotropic hormone, which an adrenal cortex must stimulate the release of corticosteroids, mineral corticoids, and androgens as well. And thyroid stimulating hormone, which stimulates thyroid gland to produce thyroxine. We've got follicle stimulating hormone, which causes gonads. Here we've got to produce estrogen. We've got lutein hormone, which is produced by the ovary, and progesterone as well here. And we've got in male lutein stimulating hormone, with in testes produces testosterone, and in the mammary glands, prolactin stimulates in the breast stimulation of the prolactin synthesis. Okay, and the production of it. So this is just a small part. You will watch it later, and you will read it in the book. Okay. So now let's start with the adrenocorticotropic hormone, which is called corticotropin. This is the synthesis, the short form, and also yes, widely spread in the literature. So corticotropin, it means adrenocorticotropic hormone. Okay, so we first in the hypothalamus, as I said, corticotropic releasing hormone is produced. We've got here. Then it's stimulated peptide pro-opiomelanocortin according to produce adrenocorticotropic hormone, okay, from the myelin cortex. Yeah, adrenocorticotropic hormone, or ACTH, or corticotropin, okay? And here we've got the mechanism of it. A corticotropin releasing hormone is used diagnostically to differentiate between Cushing syndrome, which you're going to read it in the book, and ectopic adrenocorticotropic hormone producing cells, okay, or tumors. Also, not just corticotropin releasing hormone, but we've got a gamma melanocyte stimulating hormone, which takes part into the formation of the melanocytes, which is the coloration of our skin, and beta glycoprotein, which is precursor of the endorphins. Endorphins, as you know, the happiness hormone, so-called. Okay. So, highest concentration of corticotropin we've got at 6 a.m. in the waking morning, okay, and the lowest, obviously, we've got in the late evening. So, a prescription during insufficiency should take into consideration the highest concentration, which is normally produced, and the lowest, okay. In the evening, we would need the much more bigger dose, okay, to prescribe. So mechanism of action, what does the target organ is adrenal cortex, obviously, which produces adrenocorticotropin or corticotropin. It binds to specific receptors, and by occupying these receptors, we've got G protein coupled process activation, which leads to increased cyclic adenosine monophosphate, or cyclic AMP, as we all know, and this all stimulates adrenocorticosteroid synthetic pathway, which includes chlorelastolone, pregnenolone, and so on. And it starts synthesis and the release of the adrenal corticosteroids and the adrenal androgens, okay? And therapeutic uses. What are the therapeutic uses of the corticotropin? Corticotropin, as I said in the beginning, it's a diagnostic tool for the differentiating between the primary adrenal insufficiency, which includes Addison's disease, and also associated with the adrenal atrophy, and also secondary adrenal insufficiency, which is caused by the inadequate secretion of adrenocorticosteroids by the pituitary, okay? Tropic hormone, okay? And also releasing factors somehow can be identified, okay? Secondary to pituitary hypofunction. And therapeutically, how we use corticotropin. Their extracts are taken from the anterior pituitaries of domestic animals, or they are synthesized from the human adrenocorticotropic hormone, okay? It consists of amino-terminal 24 amino acids of the hormone, as in preferred for the diagnostic of adrenal insufficiency. Adrenocorticotropic hormone is used in the treatment of the multiple sclerosis, and as well as this is a very devastating disease, as you all know, and also West syndrome, which is infantile spasm over the generalized seizures in the infants that are usually resistant to multi-therapies or the multi-drug therapies with the anti-epileptic. So we can use corticotropin or adrenocorticotropic hormone for that, okay? Toxicities include, or other effects are similar to of the corticosteroids, which includes corticosteroids. We're going to talk about the glucocorticoids and corticosteroids. We're going to talk about them later, but still, remember this as the various effects, okay? Osteoporosis, it is the, how to say, calcium deficiency in the bones. You can see that in the structure. For example, in the femoral bone and the femur, we've got the sponges-like structure, so it's very poor with the minerals and cortical minerals and calcium, so it is very prone to fractures. Okay, you can see pathologic fracture which occurs in the femur and as well as in the vertebra. Okay, vertebral the bodies and are also poor with the calcium, poor with the minerals, so they are very fragile and prone to fractures. Okay, and the most likely glucosteroid treatment and corticosteroids and are how to call the reason to cause osteoporosis and also vertebral fractures as well, and vertebral problems. Hypertension is also one of the due to release and stimulation of adrenal gland. The hypertension is a very common adverse effect. We've got peripheral edema or pitting edema. You can see it in the picture due to unknown mechanism. We've got hypokalemia, decrease in the potassium level, which also should be monitored during the treatment with the electrolyte balance, should be checked frequently. And emotional disturbances like mood swings, change in the mood with no reason, and also increased risk of infection. They all corticosteroids, glucocorticoids, and including corticotropin, they all somehow decrease the local immune system, and that is why most of the patients on this kind of treatment are prone to infections, bacterial infections, viral infections, fungal infections, and so on. So risk of all types of infections is increased with this treatment. These are what you should have remembered about the corticotropic. Now let's look at another hormone which is also produced by anterior pituitary gland. This one is called growth hormone. Another name for that, somatotropin. We had adrenocorticotropic hormone with corticotropin, and the second, the most important one is growth, not the most, but one of the important ones is growth hormone or somatotropin. As you can see, tropins are the common suffixes for the pituitary, anterior pituitary gland hormones. Okay, so as with adrenocorticotropin corticotropin, we've got the beginning of the cycle is still in the hypothalamus. So hypothalamus produces growth hormone releasing hormone that leads to growth hormone production. Okay, and hypothalamus also produces somatostatin, which is growth hormone inhibiting hormone. Okay, somatostatin stops somatotropin production, releasing hormone stimulates somatotropin production. This is how it works. So, we said the corticotropin, the peak of the corticotropin, in the blood was at 6 a.m. and the late night it was the minimum concentration, while growth hormone is produced at much more capacities and amounts at night during the sleep. So this is different. Yeah, during the sleep it's most likely to be produced most often. That is why sleep is an important part into when your parents are saying that you should sleep well, sleep early in order to grow big. That is somehow has truth in it. Okay, so with increasing age, growth hormone secretion decreases. That leads to decrease in the lean muscle mass and leads to processes that are linked with the aging. Okay, that is why growth hormone is most likely to be called Yeah, I will tell you what it's called then. Stimulating of the protein synthesis process, stimulating cell proliferation, also both bone growth and increased formation of proline, that is from proline boost cartilage synthesis, not just a bone synthesis, but also cartilage synthesis is increased. Okay. Synthetic human growth hormone is produced using recombinant DNA technology, and it is called somatotropin. Okay, synthetic adrenocorticotropin was from domestic animals and from pituitary glands of the human. Okay, but this one is produced by the recombinant DNA technology. Yes, and it is called somatotropin. Okay. And growth hormone from animal sources is ineffective in humans, not like corticosteroids, which are taken from domestic animals. Okay, this one is ineffective. That is why DNA recombinant technology is used to gain artificial somatotropin, not somatotropin, but somatotropin, which is the synthetic somatotropin. Okay. So mechanism of action, how as I said, it stimulates bone synthesis, cartilage synthesis, growth processes in the body. The physiologic effects are observed directly at its target. It's included others as mediated through the somatomedins, which one is one of the example is insulin-like growth factor 1 and 2, which take the lead part in the formation of the acromegaly, which is the growth and the permanent parts of the body. In acromegaly, insulin growth factor, intern-like growth factor 1 levels are constantly high, reflecting elevated growth hormone. Okay. And therapeutic uses. How can we use somatotropin or somatotropin, which is synthetic one? It is used for the treatment of the growth hormone deficiency or growth failure in the children, obviously. A hypopituitary, it is decreased function of the pituitary gland with the normal thyroid status, or okay, just the solely hypopituitaries, essential for the successful somatotropin therapy. And for the growth failure due to Prader-Willi syndrome, which is genetically inherited disease, and one of the features is the growth failure. So for that, we can use somatotropin. And also management of the AIDS wasting syndrome, which is wasting syndrome that is linked with yes, AIDS and the short bowel syndrome, because the most of the patients are anorexic, or the cachexia is one of the common features. The bones and the cartilage and the muscle lean muscle mass decreases. So in order to increase it, we can use somatotropin. Short bowel syndrome, it is when there is insufficient absorption and malabsorption we've got, and the person cannot digest well, cannot take important minerals, electrolytes from the food. So and the lean mass, muscle lean mass decreases because of this reason, and we can add a synthetic somatotropin in order to increase the muscle mass. And growth hormone replacement in adults with confirmed growth hormone deficiency due to other reasons. And growth hormone is administered to men over 60 years of age for 6 months, increase their lean body mass and bone density as well, and skin thickness. So adipose tissue mass was decreased. So it has a good effect. Lipids did not decrease, but bone mass and muscle mass increased. So growth hormone is like anti-aging hormone. As I said, that is what it calls. So it stopped, and the men over 60 years, it's they managed to stop aging from that, because they decrease adipose tissue mass but increase bone and muscle mass. Okay, if used by some athletics, they are seeking to enhance their performance, so that is why it's not approved for this purpose, okay, anymore. And so some who have taken it have developed diabetes, which is linked with growth hormone, because insulin-like growth hormone is also very typical to cause diabetes, and that is why that was not advised to use for that reason. Half-life of the growth hormone is short. It's about 25 minutes. It means that in 25, half of the growth hormone is already left our body, or out of the body. Okay, it induces the release of insulin-like growth factor 1, formerly somatomedin C, which is called like this, from the liver, which is responsible for subsequent growth-like actions. Okay, it has, however, short half-life, but it induces the release of IGF-1, which has the properties to growth-like actions. Okay, should not be used in pediatric patients with closed epiphysis. What does this mean? In order to monitor the growth in the children, we're taking x-rays of some bones. For example, we can take the x-ray of the palm and we can check epiphysis. It is the part of the bone which indicates if the children is still growing or not. So if the bone epiphysis are closed, it means they are not cartilage anymore. They are all bony. Okay, they have no capacity to grow any longer. So in this case, if they are closed, we're not given any additional growth hormone because there is nothing they can affect. So there is no target for that. They are already closed. So that is why we're checking those epiphyses in patients with increased intracranial pressure as well, diabetic retinopathy, and obese patients with Prader-Willi syndrome. They are not prescribed. Okay, those are the contraindications to prescribe growth hormone. And now we said that somatostatin is the one that inhibits growth hormone production. So growth hormone inhibitor hormone, which is also important to know, because somatostatin binds to 2 and 5 receptors, releasing hormone receptors, which suppresses growth hormone and as well as thyroid stimulating hormone release. So it not just stops the growth hormone production, but also thyroid hormone function. It interferes with the thyroid glands as well. Small polypeptide, this is the small polypeptide that is found in neurons, in the intestines, and in the pancreas as well, not just in CNS, but also in intestines and in the pancreas. It inhibits release of growth hormone, which is from the brain, insulin because it's in pancreas as well, and glucagon and the gastrin as well, not just growth hormone, but insulin, glucagon, and gastrin. So the side effects will be linked with the deficiencies of these 4. Okay, osteolyte is the synthetic somatostatin. Now, octopeptide analog of the somatostatin, which is used in the dapper form. It is long duration forms, and yes, they decrease growth hormone, insulin, glucagon, and gastrin. I repeated myself. So how can we use it? On this picture, can you recognize that this is? I hope you can. This is acromegaly, so enlargement of the prominent parts of the body, which include limbs and hands, fingers, and legs as well. The size of the shoes increases, and also nose, chin, tongue, and so on, prominent parts, and the ears as well. And the treatment of acromegaly caused by hormone secreting tumors like Adenomes of the high pituitary gland adenomes, or microadenomes, microadenomes that doesn't have change anything. An analog of the human growth factor is pegovisomant. Okay, pegovisomant is employed in the treatment of acromegaly that is refractory to other modes of the surgical or the radiological or pharmacologic interventions. Okay, an antagonist at the growth hormone receptor and results in the normalizing of the insulin growth-like factor 1, which levels are increased during acromegaly, as I said before. Secretory diarrhea is associated with the tumors producing vasoactive intestinal peptide, which is VIPomas, or VIP is a vasoactive intestinal peptide. VIPoma is the tumor producing vasoactive intestinal peptide in increased amounts. So this secretory diarrhea caused by VIPomas can be also can be used as a therapeutic tool. Okay. Adverse effects. What are the adverse effects? It includes diarrhea, it includes abdominal pain, flatulence, as well as nausea, steatorrhea. It is in the feces increased level of the lipids, the steatorrhea, and gallbladder empty is delayed. That is why precipitations are also common, and it causes asymptomatic cholesterol gallstones. Okay, you can see here, gallstone formation is triggered with as an adverse effect. Okay. So we discussed corticotropin, somatotropin, somatostatin, and now let's talk about gonadotropin releasing hormone, and luteinizing hormone releasing hormone. Okay, a lot of hormone here. So let's start with gonadotropin releasing hormone, which is called gonadorelin. Okay, gonadorelin. This is pulsative secretion of gonadotropin releasing hormone leads to release of follicle stimulating hormone, or FSH, and luteinizing hormone, or LH, from the pituitary gland. Okay, and this leads to continuous administration that inhibits gonadotropin release as well. Leuprolide, goserelin, naporelin, and hysterelin, all the relins, as they act as agonists on the gonadotropin releasing hormone receptors. Okay, they increase the amount of the hormones themselves, suppressing production of the gonadal hormones when administering continuously. It means that negative feedback loop here. As muscle hormone levels increases in the blood, they somehow inhibit the production of stimulating or releasing hormones. Okay, so the negative feedback loop. If there is too much of the hormones in the body, they inhibit the production of releasing hormones, which then leads to decreased hormone levels. Okay, this is the important type of regulation. Effective in the treatment of prostatic cancer, endometriosis, or increased, let's say, thickness of the uterine layers. Okay, and the precocious puberty as well. Now, in women, they might cause hot flashes and sweating, and diminished libido as well. Also, depression is common, and ovarian cysts, and contraindicated in pregnancy and the breastfeeding. Okay, remember this one. They are contraindicated in the pregnancy and breastfeeding. They're not well tolerated. And in men, they initially cause a rise in testosterone, but the result is bone pain. And the hot flashes also are common in the men, and edema, swelling, and gynecomastia. It means the increase in breast size in the man. Also diminished libido as well as in the woman as well as in the man. Okay. So now let's talk about the gonadotropins separately. So they are human menopausal gonadotropin or follicle stimulating hormone or human choroid gonadotropin. So they are all glycoproteins produced in the anterior pituitary, regulating of gonadal steroid hormones. Okay, they are used for the treatment of infertility in both women and men, and also menotropins. Those are the human menopausal gonadotropins, or HMG. Menotropin, one of them. They are obtained from the urine of the post-menopausal woman, and they contain a follicle stimulating hormone or FSH, and also LH, luteinizing hormone. That is why they are used. And also we've got another one, chorionic gonadotropin hormone, or HCG, not MG. HCG, it's a placental hormone structurally related to lutein hormone, which is an lutein hormone receptor agonist exerted in the urine as well. And we've got urofolitropin, as you can see. Uro, it means from the urine. It is the FSH obtained from the postmenopausal woman and is devoid of lutein hormone. Okay, we've got three menotropins, that is contains both FSH and LH. We've got chorionic gonadotropin hormone, or HCG, which is again from LH from the urine, and urofolitropin is FSH from the urine. Okay, not LH. Okay, so those are all used during the infertility. Okay, and lastly we've got folitropin alpha or folitropin beta, that are human FSH products manufactured using recombinant DNA technology. And all of these hormones are injected via intramuscular route of the administration or subcutaneously. Injection of the HMG or human, this one, the first one, HMG, which contains both of them, FSH and LH, or plus FSH over a period of 5 to 12 days, causes a varying follicular growth and maturation, and with the subsequent injection of HCG, and ovulation occurs. Okay, so this is the treatment for the infertility. In men who are lacking gonadotropins, treatment with HCG causes external sexual maturation, and with subsequent injection of the HMG or folitropin, spermatogenesis occurs. Okay, so in the woman we start with HMG and FSH, and additionally we add HCG, and we got the ovulation. And in man, we start with ACG, not with HMG, but with ACG. And then we add HMG or folitropin, and we've got spermatogenesis. Okay. And in females, adverse effects include ovarian enlargement and a possible hypovolemia. Multiple births are not uncommon as well. Men may develop gynecomastia, as I said, increased breast size, and feminization in the men. And lastly, not the last one, but near the last one, it's a prolactin. As you know, this is the peptide hormone, also produced by the anterior pituitary gland, that is similar in the structure to growth hormone. That is linked with the breastfeeding and the growth of the child. It is secreted by anterior pituitary, as I said. It inhibited by the dopamine, acting as dopamine 2 receptors. So dopamine or the agonists that act on dopamine 2 receptors, they inhibit production of the prolactin. Increased levels of prolactin are linked with the severe headache. So that is why headache is very common during the pregnancy, because prolactin levels are already increased. Primary function is to stimulate and maintain lactation, but it also decreases sexual drive and reproductive function as well. It binds to transmembrane receptors that leads to activation of the thyroid kinase. Thyroid phosphorylation process is generated and leads to gene activation. Okay, and we've got the prolactin production. So no preparations are available for the hypoprolactinemic conditions, so conditions where prolactin levels are low. But for hyperprolactinemia or increased levels of the prolactin associated with galactorrhea or hypogonadism, it is treated with dopamine 2 receptor agonists such as bromkriptine and cybercholine or carbercholine, cybercholine, I think. So bromkriptine, cybercholine are used during hyperprolactinemia, increased levels of the prolactin. They are used in the treatment of the pituitary microadenomas and as well as microprolactinomas. Those are all the tumors of the pituitary gland, and the hyperprolactinemia or increased production of the prolactin. Adverse effects include nausea, headache, obviously, and psychiatric problems as well. So these were all hormones of the anterior pituitary gland. Now let's talk about the hormones of posterior pituitary gland. Those are just the two ones, vasopressin and the oxytocin. So this is posterior pituitary gland. That also here we've got the adrenal gland, the aldosterone kidney, and vasopressin here. That is like antidiuretic hormone. We've discussed this in the previous lecture. And diuresis is, yes, antidiuretic, as you can understand. Vasopressin and oxytocin, they are not regulated by releasing hormones. Okay, all hormones produced by anterior pituitary, including corticosteroids, growth hormones, gonadotropin hormones, and so on. All of them are under the control of hypothalamus, and it's releasing hormones, while posterior pituitary hormones, vasopressin and oxytocin, are not under the control of the under the regulation of the releasing hormones. Okay, they are synthesized in the hypothalamus, transported to the posterior pituitary, and released in the response to specific physiologic signals. Okay, as stimuli. They are non-peptide. With a circular structure due to a disulfide bridge. The reduction of the disulfide inactivates these hormones, and they are susceptible to proteolytic cleavage and are given parenterally. Okay, susceptible of the cleavage in the gastrointestinal tract. They have very short half-life, that is why they are broken down easily. So let's start with oxytocin. This is only used in obstetrics to stimulate uterine contraction, to induce reinforced labor. The sensitivity of the uterus to oxytocin is increased with the duration of the pregnancy when it's under estrogenic dominance. Okay, as the duration of pregnancy increases, oxytocin also sensitivity to the uterus of the uterus is increasing as well. It's used to induce labor. So the only drug to induce labor, drugs administered intravenously, because contractions of the uterus are stimulated. It causes a milk ejection by contracting the myepithelium cells around the mammary alveoli. So milk ejection is also not production like prolactin, but ejection. Okay, hypertension and also uterine rupture is possible. So those are the adverse effects: the water retention and edema and fetal death, even fetal death. Okay. Antidiuretic and the pressor activities are very much lower than with the vasopressin, but still they are present. And they are contraindicated in abnormal fetal representation or the location. It means when the fetus is in diverse positions. It means the head is up and legs are down, or they are in the longitude or transverse location. So they are not given because they stimulate the labor, but in this wrongful position, the labor might go wrong. Okay, so that's this why they are contraindicated in this case. Also, during fetal distress and premature birth, they are contraindicated as well. But they could cause premature birth if used unwisely. Okay, and now let's talk about vasopressin. Vasopressin, as I said in the previous lecture, we've got two receptors, V1 and V2 receptors. V1 receptor increases systematic vessel resistance, and the V2 receptor increases blood volume. V1 has the property of vasoconstriction, but both of them totally they increase arterial blood pressure. Okay, and antidiuretic and vasopressor effects are present, both of them. In the kidneys, they are produced. So in the kidneys, it binds to the V2 receptor, as you can see in the kidneys, they bind to V2 receptors. In the blood vessels, they bind to V1 receptors. V2 receptors increase water permeability and reabsorption in the collecting tubules or CT. Then they increase volume of the blood because they increase volume of the fluid totally. The treatment for the diabetes insipidus because they're, yes, you understand why. Management of the cardiac arrest as well, controlling the bleeding due to esophageal varices or colonic diverticuli. Okay, I pressed something here. I hope you're able to see and hear me well. I hope you're gonna see this afterwards. And hope is always left for me, okay? Because I'm still on my own. Okay, and for V1 receptors, which are located in the liver as well, in the blood vessels, or smooth muscles, they cause constriction of that. So they increase the vascular resistance, and that is the mechanism of the arterial increased arterial pressure. And what they cause, they might cause water intoxication because the fluid retention is increased, and hyponatremia. This is illogical, but really the decrease in the sodium levels are also common. Headache and the bronchoconstriction is also tremors as well. Patients with the coronary artery disease, epilepsy, and asthma are contraindicated because you understand coronary artery disease got already squeezed the coronaries and insufficient blood flow to the heart. So we use vasopressor. It means constriction is even worse, so it worsens the condition. Epilepsy because it might cause the seizures or the decrease the threshold to the seizures, and asthma because of the bronchoconstriction, obviously. They modified to desmopressin because all those side effects that vasopressin had, we've got sympathetic desmopressin. There's minimal activity at the V1 receptors, though it has no pressor effects, but it has, yes, antidiuretic effects as well. They prefer for the diabetes insipidus and nocturnal enuresis, and its longer acting one is vasopressin. Okay, longer acting than vasopressin. Desmopressin, they use as the sprays, but not like this. Okay, they use as a nasal drops, administered intranasally or orally. Nasal formulation is no longer indicated for enuresis due to reports of the seizures in the children using the nasal spray, but still they are used in adults. Now, for example, with the diabetes insipidus that is caused due to pituitary adenomas and the resection and so on, a local resection of them after post-surgical patients. A local irritation may occur with the nasal spray as well. So that was all with the pituitary hormones, anterior and posterior pituitary hormones. You've got here anterior in your book. Okay, that was all with this. This was the first part of it. Now we have a long chapter ahead of us, so I will not show you the questions here because I have no one to show it to. So I will just go on after a few minutes. I will go on with the second part of our today's lecture. It is the anti-diabetics, okay? The treatment of diabetes as well. Important, very, very, very important topic, okay? And a long one. And lastly, we will discuss corticosteroids. Okay, I will. How can I open this? Oh, yes, I'm opening this one. So we've got. I will start presenting, but I will give you a 5. Not you, because I'm all alone. I will give myself a 5-minute break. I hope you wouldn't mind, okay? Yes, I am presenting and I will give myself a break. See you in 5 to 10 minutes, okay? Okay, hello, I'm back, my future doctors, and we're going to continue on our topics. One of the, yes, I think very important ones, okay? Let's go on with the insulin and other glucose lowering drugs or anti-diabetic drugs. So we've got here on illustration the pancreas, which is not just the endocrine but as well as exocrine gland. Pancreas as an endocrine gland produces the peptide hormone called insulin and as well as glucagon and somatostatin. We said that before, the one that inhibits the growth hormone production. And we've got the as an endocrine gland that produces digestive enzymes, okay, that take part into the process of digestion. And islets of the Langerhans that are called beta cells, they produce insulin, while alpha cells produce glucagon, and also we've got gamma cells that produce our somatostatin. Okay, beta are responsible for the production of the insulin. Okay, the homeostasis of the blood glucose levels depends entirely on the pancreas and on the production of the insulin. Okay. And then diabetes mellitus, the most widespread disease that we've heard of it. Diabetes mellitus, it's a heterogeneous groups of syndromes characterized. Sorry for the noise. I've got some constructions in my house, and this is why I have to stop very frequently because I've got a lot of noise in my house. Okay. So, as I said, a heterogeneous group of syndromes characterized by the elevation of the blood glucose caused by a relative or absolute deficiency of the insulin. We've got two types of diabetes. Type 1 diabetes, it's insulin dependent diabetes mellitus, and we've got type 2 diabetes, that is non-insulin dependent diabetes mellitus. And also we've got gestational diabetes, which is a totally different condition that is linked with, as you can understand, with pregnancy. It causes fetal macrosomia, shoulder dystocia, and some of the neonatal hypoglycemia as well. Okay. And we've got diabetes due to other causes, which include genetic defects or other medication. We said that some of the drugs might cause diabetes insipidus. And also the pituitary hormones might also, pituitary adenomas, hormonal disbalances might lead to diabetes insipidus, which is reversible and treatable or can be treated, okay? And let's talk about diabetes 1 first. It is most likely to develop in a puberty or show its signs in the early adulthood. It is absolute deficiency of the insulin caused by massive beta cell necrosis, the beta cells that are responsible for the production of the insulin, due to autoimmune mediated processes directed against the beta cells and triggered by invasion of some of the viruses or other chemical toxins. So, inflammatory or autoimmune mediated processes that cause massive destruction of the beta cells that leads to diabetes type 1. Okay. And the symptoms of it include this, as in all of the diabetes, it includes polydipsia, which is increased amount of the water intake, increased thirst, polyphagia, hunger, an increased eating habit, polyuria, increased urine production, and the weight loss. These are all linked with the diabetes type 1, okay? It requires exogenous insulin to avoid a catabolic state that results from its from the insulin deficiency. Okay, and it's characterized by hypoglycemia and some of the life-threatening ketoacidosis. So remember, ketoacidosis is an emergency state caused by diabetes type 1. Okay, linked with diabetes type 1. The causes of diabetes, well, as we said, it's autoimmune destruction of beta cells, but it's the normal post-absorptive period at low levels of the circulating insulin, and it suppresses lipolysis and proteolysis and glucogenolysis. And the burst of the insulin secretion is due out 2 minutes after ingesting your food, ingesting a meal, in a response to the transient increases in the levels of circulating glucose and amino acid, and this all lasts up to 15 minutes, followed by the postprandial secretion of the insulin. And we've got no functioning beta cells because they are all destructed or necrotic due to autoimmune processes. It leads to development and the progression of neuropathy, nephropathy, and retinopathy. Okay, it means yes, sensory distortion. Nephropathy is, you can understand, linked to the kidneys, and retinopathy linked with the destructive processes in the retina, loss of sight, and so on, worsening the sight. Directly related to the extent of glycemic control. And lastly, blood levels of the glucose or hemoglobin, glucurinated hemoglobin is measured, hemoglobin A1C, you can see, in order to indicate diabetes type 3 and to point out the diagnosis. And what will be the treatment? Obviously, the treatment, we've got exogenous injected insulin to control hyperglycemia and to avoid ketoacidosis, which is the fatal complication, can be a lethal one, okay? And also maintain acceptable levels of glucose, glycolyzed hemoglobin, as I said, HbA1c. And phase of formation of the glycolyzed hemoglobin is proportional to the average blood glucose concentration over the previous 3 months. So glycolyzed hemoglobin is the powerful indication, and it provides a measure of how well treatment has normalized blood sugar, okay? Not just one single test, okay? The goal is to maintain blood glucose concentration as close as possible to the normal levels of the blood glucose concentration, and also to avoid wide swings in the glucose levels that may contribute to the long-term complications, okay? This frequent self-monitoring is one of the tools we can use, and the treatment with the insulin injections, obviously. And a continuous subcutaneous insulin infusion we can do through insulin pump. As you can see, this is the insulin pump, the example of it. It is a program to deliver a basal rate of insulin secretion that allows the patient to control delivery of the bolus of insulin to compensate for the high blood glucose or in anticipation of the postprandial needs. Okay, if you're planning to ingest a glucose-rich meal, you are going to increase the levels of insulin according to the meal. Okay, you can control the amount of the insulin that is ingested by increasing very easily the pump, increasing or decreasing the levels of the insulin through the pump. Transdermal, also we've got buccal, we've got intranasal insulin, and currently these are all under investigation. They are not frequently used. We use insulin injections, subcutaneous injections, and we can use insulin pumps as well. And we can use amylin with diabetes type 1. It is a hormone that is co-secreted with insulin from the pancreatic beta cells. So it is some kind of stimulated, and also its production is followed by food intake. And pramlintide is a synthetic analog of amylin that may be used as a adjuvant treatment to insulin therapy. Okay, and we'll discuss it after that in the end of the treatment. And the type 2, we talked about type 1. Let's discuss now type 2 diabetes. It is influenced by the genetic factors, by aging, obesity, and peripheral insulin resistance as well, rather than by autoimmune processes or the viral infections that were the cause of the type 1. Okay. It's the metabolic alteration observed are milder than those described for the type 1. So ketoacidosis is not common with the type 2 diabetes, not like type 1, okay? Type 2 diabetes typically are not ketotic. Long-term clinical consequences can be just as devastating, including vascular complications, subsequent infections that can lead to amputations of the lower limbs, and so on. These are just as devastating as with any types of diabetes. So, what are the causes of diabetes type 2? Most of the frequent, the pancreas retains some beta cell function. It means not all of the beta cells are eliminated from the picture, but some of the beta cells retain their functioning, but the variable insulin secretion isn't sufficient to maintain the normal glucose levels and the glucose homeostasis. So the beta cells mass may become gradually reduced in type 2 diabetes, and lastly, they can be none at all. The patients are often obese in type 2 diabetes, okay? They are accompanied by the lack of sensitivity of the target organs to either endogenous or exogenous insulin. So exogenous insulin will not be sufficient with the diabetes type 2 treatment. This resistance to insulin is considered to be a major cause of this type of diabetes. That is why it is called non-insulin dependent, okay, because we've got the resistance to insulin. The treatment might include the goal of the treatment is to maintain blood glucose concentration within normal limits and to prevent the development of the long-term complications such as infectious complications, amputations, loss of sight, and so on. Okay. Weight reduction is the first measure we should take if the patient is obese. Exercise and dietary modification that decrease insulin resistance and the correct hyperglycemia. Okay, they don't treat, but they correct and they decrease the insulin resistance. Most of the patients are dependent on pharmacologic interventions with the oral glucose lowering agents. As the disease progresses, beta cell function declines, and insulin therapy is often required to achieve satisfactory serum glucose levels. Okay, at the beginning of therapy, while we still have functioning beta cells, we don't need insulin therapy, but other oral glucose lowering agents are very effective. But as the disease progresses, we've got the prominent loss of the beta cells, so it's getting closer to diabetes type 1. So we might need the extra exogenous insulin to add to our schedule of the treatment, okay? So now let's talk about the insulin. Let's talk about the drugs finally. Insulin and its analogs, okay? Insulin, as you can see on the picture or in the illustration, it's a beautiful substance. It's a polypeptide hormone consisting of two peptide chains that are connected by the disulfide bonds, okay? A precursor of the insulin is proinsulin. It undergoes proteolytic cleavage to form insulin plus C-peptide that is secreted by the beta cells of the pancreas. So, to define the levels of the insulin production, we also can define the levels of C-peptide, which is the indication of how much insulin is produced in the body. So, insulin undergoes significant hepatic extraction, and circulating plasma insulin levels may not accurately reflect the insulin production. So that is the reason why we measure circulating C-peptide to provide a better index of the insulin levels, okay? Logical, I think. So let's talk about with a few words about this insulin secretion. It is regulated by the blood glucose levels and by certain amino acids or other hormones, and as well with autonomic mediators, okay? The secretion is triggered with the high blood glucose. It means the food intake, okay? The meal ingestion, which is taken up by the glucose transporter into the beta cells of the pancreas. and phosphorylated by glucokinase, which acts as a glucose sensor or detector. The products of the insulin metabolism enter the mitochondrial respiratory chain and generate adenosine triphosphate or ATP, or the source of the energy. Okay, the rise in the ATP levels causes the block of the potassium channels, leading to membrane depolarization and the influx of the calcium ions. Okay, potassium channels are blocked, and we've got the calcium influx into the cell. And increase intracellular calcium causes pulsative insulin exocytosis. So, as you can understand from this, and the calcium plays a major role into the exocytosis of the insulin and ATP as well. And the sulfonylureas and glinids, which are the one types of the treatment of diabetes type 2, they owe their hypoglycemic effect to the inhibition of the potassium channel. So this is the one type of the treatment. Sulfonylureas and glinids, they have the hypoglycemic effect or glycemic effect by inhibited those exact potassium channels. Okay, the glucose given by injection has a weaker effect on an insulin secretion than does the glucose intake itself orally. It means the food is the best stimulator of the insulin production. Okay, when given orally, glucose stimulates production of incretin hormones by the gut, which in turn stimulates insulin secretion by the pancreas. Okay, incretins also take part into the stimulation of the pancreatic hormones. Sorry for that. That is my grams. The source of the insulin. Now let's talk from where we can get the insulin. Okay. Human insulin is produced by recombinant DNA technology using special strains of Escherichia coli, this is the bacteria, or the yeast that have been genetically altered by contain the gene of the human insulin. Okay, the pig's insulin is very close and the most similar to the human insulin. Modifications of amino acid sequences of the human insulin have produced insulin with different pharmacokinetic properties. We've got insulin lispro, we've got insulin aspart and glulisine that has a faster onset and a shorter duration of action than the regular insulin because they do not aggregate or form complexes. So, okay, the formation of the insulin, their onset and the duration of action, that are the criteria that differ the insulin from insulin products and insulin analogs from each other. So those are the criteria for the classification. And glargine and the dentamine are the long-acting insulins and show prolonged duration of action and flat levels of the hormone following injection. Okay, here we've got the scheme that represents all types of insulin analogs due to duration of action and also onset of the action. Okay, we've got here rapid onset insulin analogs, which includes insulin rispro, aspart, and glulisine. We've got short-acting ones, which have a longer duration, as you can see, but they are not so rapid-acting ones. This is the regular insulin. We've got intermediate ones, which, as you can see, their duration of action is up to 18 hours. Okay, this one is intermediate one, but the peak of the concentration occurs within the 5-6 hours, not like rapid ones, which is within the hour. Okay, but this one has a short duration, just 5 hours. Okay, this shows this graph. The horizontal line shows the duration of action in hours, and this vertical line shows the time they achieve their peak. Okay, a long one has a 24-hour duration of action, but and also it is peakless one. The term is and the peakless, you can see we've got maximum concentration within 6, 7, 8 hours, but it how to say contains the the same concentration is maintained for the long period of time, and then we've got the drop in concentration, and here we've got the less of the drug. And also we've got another peak one, glargine, which has a longer duration of action, but also highest concentration occurs much quicker than with the datamine. And we've got another long peakless, which is degludec. This one as longer than 24 hours. It has more than 1 day duration of action. Okay, this one, long ones are called peakless insulin. Okay, so how we administer insulin. This is, as I said at the beginning, it's a polypeptide that is easily degraded in the gastrointestinal tract if it's taken orally. That is why they are never ever prescribed orally, because they cannot be effective. They are either subcutaneous injections on the around the umbilicus on the stomach, or around on the most likely and the deltoid muscle, okay, under the skin. Administered by subcutaneous injection, you can see in a hyperglycemic emergency, regular insulin is injected intravenously only in hyperglycemic emergencies, okay, when we need to achieve the peak as fast as possible. And a continuous subcutaneous insulin infusion through the insulin pump, which I showed you, has become popular because it doesn't require multiple daily injections, and you can control by you got somehow remote control if the levels of the insulin. You can increase and decrease the doses within the just the pushing buttons. Okay, dose, site of injection, blood supply of the site of injection, and as well as temperature and the physical activity can affect the duration of action of the insulin and its analogs. Insulin is inactivated by insulin degrading hormone enzyme, which is called insulin protease. Protease means breaking down the insulin, which is found mainly in the liver and in the kidneys as well. So what are the adverse effects of the insulin? The symptoms of hypoglycemia, obviously, they are used for hyperglycemia to decrease levels of glucose. But if there are dosages not controlled, they might cause hypoglycemia, or the decreased levels of the glucose in the blood. That has the symptoms like headache, anxiety, tachycardia, heart palpitations, confusion, vertigo, diaphoresis. It means increased sweating, lipodystrophy as well, and hypersensitivity. Long-term diabetic patients commonly do not produce adequate amounts of counter-regulatory hormones like glucagon, like epinephrine, cortisol, or the growth hormone, which normally provide an effective defense against the hypoglycemia. So hypoglycemia and hypoglycemic shock or the crisis is most common with the patients who are on long-term treatment with anti-diabetics. Okay, and the weight gain is also common, and lipodystrophy means the less common with the human insulin, but with other types of insulin, very common. Lipodystrophy means the disturbance or the disturbance of the homeostasis between the lipid production and the destruction. Allergic reactions and local injection sites are also common, and diabetes with the renal insufficiency may require adjustment of the insulin dosage, because the insufficiency is the reason of the clearance is decreased, so we should adjust the dosage, including to the how deep the insufficiency is, how severe it is. Now let's discuss the insulin preparations. First, rapid acting ones, which had a very high quick peak, and the short acting ones. Okay, rapid acting and short acting insulin preparations, which include insulin, regular insulin itself, the insulin Lispro, Esport, and glulisine. These are the four representatives of rapid acting and short acting insulin. It means they have quick onset of action but short duration of action. Okay. Regular insulin is a short-acting, soluble, crystalline zinc insulin. This is the regular insulin. Crystalline zinc insulin, which is usually given subcutaneously or through the IV injections during emergencies. So remember, during emergencies, we can inject intravenously regular insulin. Remember, there is crystalline zinc insulin or regular zinc insulin is injected IV during emergencies, and also they rapidly lower blood glucose levels. Regular insulin, insulin Rispro, and Aspart are pregnancy category B, and insulin glucagon is pregnancy category C. By the FDA, by Food and Drug Administration, that gives the categories. Lispro, Aspart, and glucagon, they are rapid-acting ones, offer more flexible treatment regimens, and may lower the risk of hypoglycemia. Lispro is lysine and proline. It has positions about 24 to 29 in the beta chain. This is just a structure. So it has peak levels achieved within the 30 to 90 minutes. Okay, a half an hour is just enough to achieve the peak after the injection, I mean, and as compared with the 50 to 120 minutes for regular estrogen, it has a shorter duration of action. And aspirin and glucagon also, they are administered 50 minutes prior to the meal, because immediately followed by milk it can be. And this one, glucagon, can be taken after either 50 minutes before the meal or within 20 minutes after starting a meal. An Allspat should be administered just prior to the meal or up to 15 minutes followed by meal. And all of the rapid-acting formulations, or Lispro, Aspart, and glucagon, they are suitable for IV administration. Okay, they may also be used as external insulin pumps as well. Okay, remember, short-acting but rapid-acting ones can be used IV, but the regular insulin is most commonly used in IV. Now let's talk about intermediate acting insulin, which is neutral protamine pagidon, or NPH. This is suspension of crystalline zinc insulin, combined as a neutral pH with a positively charged polypeptide protamine insulin isoprene. So then they have duration of action intermediate because they have delayed absorption from its conjunction of the with the protamine, forming a less soluble complex. So the complex is formed, that's why they are delayed. Their absorption is delayed. Okay, they should only be given subcutaneously, never intravenously. Remember, intermediate acting insulin never given intravenously, and they are useful in the treatment of forms of diabetes type 1 and type 2, and except diabetic ketoacidosis, which requires emergency treatment and emergency intravenous injection. Okay, in diabetic ketoacidosis, we use rapid-acting, short-acting ones because they are allowed to be given administered intravenously. They are used for the basal control and given along with the rapid and short-acting insulin for the mealtime control as well. There is a similar compound called the neutral protamine Lispro, or NPL insulin, that is only used in combination with insulin Rispro. So short-acting ones with the intermediate-acting ones is the also regimen of the treatment. Now let's talk about long-acting insulin preparations, which were called peakless insulins because they achieve their plateau. They not like this. Ow, ow, ow. Okay. Someone just tripped over my internet cable. I hope I have not lost connection. Yes, that is how working from home works. Yeah, with lots of problems and inconveniences. Okay, I think I'm good. Just my grams tripped over my internet cable and my piece just plugged off. So I hope I haven't lost anything. So let's go on talking about long-acting insulin preparations, which includes first insulin glargine. Large, you can understand if they are long acting, remember like this. Isoelectric point of insulin glargine is lower than the human insulin, leading to precipitation at the injection site and extending its duration of action. Do you understand? They produced the precipitations or congregates or they aggregate at the site of injection. That is why their longer duration of action is extended. Okay, it has slowest onset of than intermediate ones, or logically, and they have a flat, prolonged hypoglycemic effect with no peaks and must be given obviously subcutaneously. Okay, that is why they are called peakless insulin. Okay, insulin glargine. And insulin determine, which is fatty acid side chain and has its association to the albumin, it forms even bigger molecule. They have slower dissociation from albumin, and it results in a long-acting properties similar to with the insulin glargine. Neither insulin determine neither glargine should not be mixed in the same syringe with the other types of insulin, because doing so might alter the pharmacodynamics and pharmacokinetic properties of both of the drugs. So they should be given with a different syringe, okay? If we are again prescribing a combined therapy with long-acting and intermediate-acting ones, okay? So now let's talk about standard treatment versus intensive treatment of diabetes. Standard treatment involves injection of insulin twice daily. Intensive treatment seeks to normalize blood glucose through more frequent injections, like 3 or more times in a day, monitoring glucose levels as well. Target mean glucose level is 154 milligram deciliter or even less. A normal mean approximately 150. This is for the yes, and if given in milligram deciliters. Frequently, if the hypoglycemic episodes, as well as ketoacidic coma, ketoacidosis, and even seizures due to excessive insulin, is higher with the intensive treatment regimens. Okay, that is why standard regimen is more safe. Patients on the intensive therapy show a significant reduction in the such long-term complications like retinopathy, like nephropathy and neuropathy, compared to the patients with the receiving standard treatment. Standard therapy is more safe, but the intensive care is decreases the all types of complications that lead to retinopathy, nephropathy, and neuropathy, and so on. Intensive therapy should generally not be recommended for the patients with long-standing diabetes and significant microvessel complications, advanced age, and those who are with hypoglycemic unawareness, okay, who cannot control the levels of blood and cannot monitor them as well. Intensive therapy has not shown any significant reduce of microvascular complications for diabetes, but it showed the decrease in the retinopathy, nephropathy, and neuropathy. But that doesn't mean that intensive treatment is somehow more prevalent than the privileged with the standard treatment. Okay, standard treatment is safe and requires just a twice insulin intake. It is more convenient for the patients with the long-standing diabetes. Now, insulin combinations can be 70% intermediate ones and the plus 30% regular ones. 50% of each can be, and 75% of and 25%. Okay, these are how regimens are divided. And the amylin, I said that the amylin also is the product of our pancreatic beta cells. And synthetic amylin, which is called pramlintide, also can be used as a substitute for insulin and for the treatment, because it delays gastric emptying, it decreases postprandial glucagon levels, and also increases satiety. But side effects include weight gain, nausea, vomiting, and hypoglycemia or hypoglycemic shock is also common for that. So synthetic amylin, I said this is pramlintide, indicated as an adjuvant to the mealtime insulin therapy in patients with type 1 as well as type 2 diabetes. They're acting on the amylomimetic. They delay gastric emptying, decrease postprandial glucagon secretion, and improve satiety. They administered by subcutaneous injections or should be injected immediately prior to meals. The dose of the rapid or short-acting insulin should be decreased by 50% prior to meals to avoid the risk of severe hypoglycemia. So with the combination of the short-acting or rapid-acting plus amylin, their short-acting and rapid-acting should be decreased their dosage and by 50% because the risk of hypoglycemia is increased with the combination therapy. Okay, they may not be mixed in the same syringe with any types of insulin preparation, again, because it interferes with the pharmacokinetic properties and with pharmacodynamics as well. Adverse effects are mainly gastrointestinal, which includes nausea, anorexia, and vomiting. It should not be given to the patients with diabetic gastroparesis. It means delayed emptying of the stomach and credulous hypersensitivity as well, and a history of hypoglycemic unevenness. The patients who are not able to control and monitor their glucose levels. Okay. And now let's talk about the oral agents. We talked about the pre-insulin preparations, short-acting and rapid-acting, intermediate ones, and long-acting ones. And now let's talk about the oral agents. The first one includes insulin secretagogues. Those are the drugs that are given orally. Obviously, they are useful in the treatment of the patient who have type 2 diabetes, but no cannot be managed by the diet or exercise or any type of the lifestyle changes. And the patients who have developed diabetes after the age of 40 and have had diabetes less than 5 years. Also, those are the indications to prescribe oral insulin secretagogues. The patients with a long-standing disease may require a combination of the glucose-lowering drugs with or without insulin to control their hypoglycemia. And insulin is added because of the progressive decline in beta cells that are acute due to disease and aging. So I said at the beginning of the type 2, we've got some beta cells still functioning. That is why insulin therapy is not needed. Some insulin oral agents are just enough to control the disease. But after disease progresses, we'll get progressive loss in beta cells, necrosis, and we're getting closer to type 1. So we've got insulin resistance. That is why we need to, insulin to overcome resistance, to add the insulin itself with the plus insulin insulin lowering oral agents as well. So oral glucose lowering should not be given to the patients with type 1. I said that type 1 should not be given oral cigarettes because this is insulin dependent, and insulin and its analogs are the ones that should be given with the type 1. Type 2, insulin secretagogues, okay? The first one is sulfonylureas. I've mentioned them before. It's insulin secretagogue that promotes insulin release from the beta cells of the pancreas, which are still functioning. Okay, if we have no function of beta cells, there is no sense of giving sulfonylureas. Okay, we have no changes in effect. This is second generation drugs include the glyburide, glipizide, and glimepiride, yes, and mechanism of action, as I said, they stimulate the insulin release from the beta cells of the pancreas by blocking the ATP sensitive potassium channels that results in the depolarization and the calcium efflux. And calcium, as I said, is the important ion because it's help the expulsive excretion of the insulin. So reduction in the hepatic glucose production and increase in the peripheral insulin sensitivity. So that is why type 2 is most commonly used oral agents, because they decrease insulin resistance and increase the sensitivity to insulin, which is the main leading cause of developing diabetes in type 2. Okay, pharmacokinetics, they are given orally. As I said, they bind to serum proteins. They are metabolized by the liver, excreted by the liver or the kidney through the urine, and duration of action is 12 to 24 hours. You can see they have a longer duration, so they can be twice or once in a day given as a treatment prescribed. Okay, adverse effects include weight gain, a hyperinsulinemia, because if we're not controlling the levels, hypoglycemia, decreased levels of the glucose, should be used with a caution in patients who already have impaired liver and renal functions, okay, or insufficiency, because delayed excretion of the drug and resulting accumulation might cause a severe hypoglycemia. Renal impairment, it means that active compounds such as gluburide are not excreted well enough, and gluburide has a minimal transfer across the placenta and may be reasonably safe for the alternative to insulin therapy for diabetes in the pregnancy. So pregnancy is the very vulnerable state, and most of the drugs are not indicated during the pregnancy. It should not be prescribed, but gluburide is the drug that can be safely used during the pregnancy diabetes, okay? Yes, gluburide. Remember, pregnancy gluburide. And sulfonylureas, you can see the mechanism of action. They inhibit the potassium channels. They increase the calcium influx. We've got here calcium influx that increases ATP and the excretion of the insulin. This is the illustration how this mechanism of action works. Okay. And here are, yes, this is the continuation of it, and this is the side effects, because it has weight gain, and hypoglycemia can be severe, and some drug and drug interactions because they are metabolized in the liver and excreted through the kidneys. Okay. Another oral agents are the glinids, like yes, rapiglinide and natiglynide. Their mechanism of action is just like sulfonylureas. The action is dependent on the function of pancreatic cells. Okay, they bind to the distant site of the sulfonylurea receptor of the ATP-sensitive potassium channels, initiating a series of reactions culminating in the release of the insulin. The pharmacokinetics is well observed orally, taken 1 to 30 minutes before the meal, and metabolized by the liver through this cytochrome P450 system, and excreted through the bile, not through the urine, but through the bile. The adverse effects, obviously, all of them, glucose lowering drugs. Common side effect is hypoglycemia. The incidence of the adverse effect appears to be lower than sulfonylureas, so they can be substitutes of sulfonylureas. Drugs that inhibit cytochrome P450, like ketoconazole or itraconazole or fluconazole and clarithromycin, they enhance the glucose lowering effect of the glinids. The drugs that increase levels of enzymes such as barbiturates, carbamazepine, or rifampin, they have the opposite effect, or they decrease the glucose lowering effect. Okay, and repaglinide, that's difficult to pronounce, have been reported to cause severe hyperglycemia in the patients who are also taking rapid lowering drugs like fibrozil, or concurrent use is contraindicated. So remember, glinids in combination, pushing some buttons and this keeps jumping and popping up. Okay, let's go on. Gamfibrozil, remember, gamfibrozil and the glinids together, they are contraindicated because they cause severe hyperglycemia, and they are never prescribed in combination. Okay. Weight gain is less of a problem with the glinids than with sulfonylureas, and this is, again, agents must be used with the caution the patients who have impaired functions of the liver. Okay, and insulin sensitizers, also another types of oral agents. We've got biguanides and TGs. We've got here TGs, thiazolidines. Broke my tongue of pronouncing this one. They improve insulin action, and they lower blood sugar by improving target cell response to the insulin without increasing pancreatic secretion. So they don't interfere with insulin secretion, but they are sensitizers, sort of decreasing the resistance and increasing sensitivity to already existing insulin. Okay. They don't improve secretion, but they improve the sensitivity and decrease the resistance. Okay, remember this one, sensitizers. Okay, biguanides, which is one of the well used, well known, is metformin, is one of the insulin sensitizers. They decrease glucose production. Glucose absorption is also decreased, and glucose uptake is increased. So glucose storage, it takes place. So within the usage of the metformin, and some gastrointestinal adverse effects are known, like nausea, vomiting, diarrhea, and sometimes even constipation. And weights also what is disturbed here. And why we have here during lactic acidosis is very common to be caused with the usage of the metformin called lactic acidosis. Okay, remember this. We'll talk it about it. Okay, now let's discuss metformin further. It's insulin sensitizer, increases glucose uptake and used by the target tissues. It decreases insulin resistance. As I said, it doesn't promote insulin secretion, so hyperinsulinemia is not a problem. So hypoglycemia is also not so serious in this case. Mechanism is by inhibiting hepatic gluconeogenesis. It means production of the new glucose molecules, or genesis of the glucose is inhibited. Excess glucose produced by the liver counted as a high blood glucose on waking in the morning. Okay, it slows intestinal absorption of sugars and improves peripheral glucose uptake and utilization. It reduces hyperlipidemia as well, LDL or low density lipoproteins, and also VLDL or very low density proteins. Cholesterol concentrations fall and high density cholesterol rises. It means good lipids or HDL, good lipoproteins increase, and bad ones like LDL and VLDL decreases. So it improves the lipogenesis and balance homeostasis of the lipids as well. This effect may not be apparent until 4 to 6 weeks of users. Okay, they are not so prompt to appear. Loses weight because of the loss of the appetite can be common. And the drug of the choice for newly diagnosed type 2 diabetics, metformin is a drug of the choice. Alone or in combination with other types of oral agents or with the insulin as well. Hypoglycemia may cure when metformin is taken in combination with the insulin. So insulin, metformin might cause hypoglycemia. Otherwise, metformin is not likely to cause it. Pharmacokinetic. Yes, I said that most of the adverse effects are gastrointestinal, like nausea, vomiting, and they are contraindicated in the diabetic patients with the renal and hepatic disease, and in those with the hepatic ketoacidosis. We never use metformin or insulin sensitizers with the patients with ketoacidosis, okay, or who have the risk to develop it. Should be discontinued in the case of acute myocardial infarction, exacerbation of the congestive heart failure, and severe infections, because the complications from this treatment are also severe with this disease. It should be used with a caution in patients older than 80 years and those with the history of congestive heart failure and also alcohol abuse, and should be temporarily discontinued in patients who have undergoing diagnosis require intravenous radiographic contrast agents, because it potentiates fetal lactic acidosis that might also occur. So those are the very conditions that we should be cautious with. Long-term use may interfere with vitamin B12 absorption. Remember this one as well. And they are effective the treatment of polycystic ovary disease. This is additional effect. It has ability to lower insulin resistance, and in a woman that can result in ovulation. So therefore, the possible pregnancy that eliminates the possibility of polycystic ovary disease. And another sensitizers like biguanides, we've got TZs or glitazones or thiazolidinediones. These were TZDs, and their insulin is required for their action because they don't, again, I repeat myself, they don't interfere with the insulin secretion. They don't increase the insulin secretion, but they decrease the resistance and increase the sensitivity to already existing insulin. Okay, these drugs do not promote its release, as I said, from the pancreatic beta cells, so hyperinsulinemia is less likely to be caused. Troglitazone is the treatment required for the treatment of the type 2 diabetes that was withdrawn after a number of the deaths from hepatotoxicity. Proglitazone and rosiglitazone also are the examples of TCDs. Their mechanism, I said, they are activating target cell is peroxisome proliferator activated receptor gamma or PPR gamma nuclear hormone receptor that increase insulin sensitivity and adipose tissues as well, in the liver and then the skeletal muscles. The hyperglycemia, hyperinsulinemia, hypertriglyceridemia, and elevated glucose hemoglobin levels are improved. LDL levels have increased with the rosiglitazone as well. HDL will decrease with both of the drugs. And so let's discuss the mechanism. So they increase the nucleic, this one is the nuclear hormone receptor PPR gamma. There is the mechanism of TZDs, how the TZDs work. They increase insulin sensitivity, not just in the liver because they decrease the insulin production, but also in skeletal muscles and also in fatty acids, and the fatty acid degradation is also increased. So yes, here proglitazone and rosiglitazone were the examples of TZDs. They have, yes, a increased HDL, increased LDL. They might cause a loss of the weight and or edema, peripheral edemas also, and they are very hepatotoxic. Remember this one, they are hepatotoxic. TZDs are hepatotoxic, okay? The adverse effect is, sorry, yeah, that's from the hepatotoxicity in patients who take glitazone. It's recommended that liver enzyme levels are checked during the medication. Okay, ALT, AST also should be monitored closely with this type of treatment. Other uses include the polycystic ovary syndrome. Yes, and because they call stimulation of the ovulation in the woman. Another, I think we're close to the end, and these are oral agents like alpha glucosidase inhibitors. You can see here, they inhibit alpha glucoside or acarbose and miglitora. The examples of this, they are inhibit in the acarbose and magnetoptase used for type 2 diabetes. Their mechanism of action, they are taken at the beginning of the meal, delaying the digestion of the carbohydrates. So they decrease the digestion of that, resulting in lower postprandial glucose levels. Reversibly inhibited membrane-bound alpha glucoside in the intestinal brush border, you can see here. And the enzyme is responsible for the hydrolysis of oligosaccharides to glucose and other types of the sugar. Acarbose also inhibits the pancreatic alpha amylase, thereby interfering with the breakdown of the starch to oligosaccharides as well. When postprandial rise and the blood glucose is blunted, neither stimulate glucose release or increase glucose action in target tissues. So as a monotherapy, they do not cause hypoglycemia as well. However, when used in combination with sulfonylureas or with insulin, hypoglycemia may develop. And hypoglycemic patients treated with glucose rather than the sucrose, because sucrose is also inhibited by these drugs as well. Okay, and side effects include constipation, flatulence, abdominal cramps, and disturbances in the GI system, because again they affect intestinal alpha glucosidase. Okay. So observed poorly is observed metabolized intestinal bacteria, metabolites are absorbed and excreted in the urine and excreted through the kidneys. Flatulence, diarrhea, abdominal cramping is most common adverse effect. And patients with inflammatory bowel disease, colon ulcerations, or intestinal obstructions should not be prescribed with these drugs because the symptoms might worsen with the usage of this carbos and so on. And lastly, we've got not last one, but the last one. This was the peptidase 4 inhibitor or DPP4 inhibitors. This one is sitagliptin and saxagliptin. They are orally active, used for the treatment of the patients with type 2 diabetes. Again, the mechanism of action includes the inhibition of enzyme DPP4, which is responsible for the inactivation of the incretin hormones such as glucagon-like peptide. And the prolonged activity of incretin hormones results in an increasing insulin release in the response to meals and the reduction in the inappropriate secretion of the glucagon. So, used as a monotherapy or in combination with sulfonylureas, metformin, glucosines, or insulin, they are very valid for the type 2 diabetes. Okay. You will read the pharmacokinetics. I'm not gonna talk, and I'm gonna say a few words about adverse effects. This includes nasopharyngitis and headache. Okay, and pancreatitis sometimes can occur with the long-term treatment of the DPP4 inhibitors. Okay, this one how it looks like. They inhibit DPP4. They decrease the levels of glucagon. The gastric emptying is delayed. And yes, insulin release you've got here. The headache is and nasopharyngitis and secretion of the mucus is also common side effect. Okay, I hope I can. And a few more slides here. Incretin mimetics. Lastly, this is oral glucose results in a higher secretion of insulin that occurs when an equal load of glucose is given intravenously. So this effect is referred to as an incretin effect, as it's markedly reduced by the type of the 2 diabetes. So gut releases incretin hormones, notable by GLP-1 and glucose-dependent insulinotropic polypeptide in response to the meal. So incretin hormones are responsible for 60 to 70% of postprandial insulin secretion. You can understand 70% is not a small one. So exenatine and liraglutide are injectable insulin mimetics that are used for the treatment of the patients with diabetes type 2, used as adjuvant therapy in the patients who have failed to achieve adequate glycemic control or with the usage of sulfonylureas, metformin, glitazone, and combination therapies as well. So those are incretin mimetics. The side effects also they cause the gastric emptying delay, and by the increased satiety as well. They decrease the body mass, decrease the weight loss is the common side effect, nausea, vomiting, constipation, diarrhea, and also GI side effects are common just like the previous drugs. Okay, this is like this, and nausea, vomiting, diarrhea, constipation, and pancreatitis. If we have any reason to think that these more drugs might cause pancreatitis, they are advised to continue if the patient experiences severe abdominal pain. Okay. And this is all. I wanted to talk about corticosteroids as well today, but as I see these subjects are, or these topics were all so long, we talked a lot today. I'm tired and I'm alone, so I'm not going to talk about corticosteroids today. So I covered just pituitary hormones and covered anti-diabetic drugs. So for the next lesson, no, the lecture, sorry for the lesson. Next lecture, we're gonna discuss corticosteroids. We're gonna discuss estrogens and androgens and the sex hormones, and we're gonna discuss thyroid hormones. Okay. I hope next lecture you're gonna attend because that's not a good. Not good for you because I'm not gonna send PPTs and you will just able to see the PPTs by watching the video. So just watch it, okay? I hope you will do well. So hope that you are all healthy and well, and that's not the reason we are skipping the classes today. So okay, I'm done because I'm alone here. But I hope for the next lecture you're gonna join me. Okay. I'll see you on Wednesday. We will discuss. We continue talking about the hormones and relating drugs. These are 3 chapters in your book, 14, 15, and 16. Very big topics as you can see. So I hope you're gonna attend next lecture. See you then. Bye bye. Have a nice weekend and have a nice day. Bye bye.